All right. Wonderful. Well, Corina, I'll start off with you.
Okay.
All right.
Which of the following abnormalities most likely is observed in these transgenic mice?
All right. So something's going on in these mice.
Yeah, all right. A research group studying the hypothalamus and pituitary gland creates transgenic mice that cannot secrete neurophysins.
Right there. Right there. Neurophysins or neurophysins.
Mhm.
What is that? What is a neurophysin?
I believe those are the ones that come out from the posterior hypothalamus.
The neurophysins come out of the posterior?
Um,
Or
the posterior pituitary, sorry, posterior.
Okay. So we
Yeah.
have anterior and posterior.
Yeah.
All right, so there is a relationship. I wouldn't say that they come out of the posterior pituitary, but there is a relationship to the posterior pituitary. Now, in relationship to that, what's so important about the posterior pituitary?
We have oxytocin and
All right, very good. Got that oxy. And
ADH, I believe.
ADH, very good.
Yeah.
Good. So here they're saying they cannot secrete neurophysins, i.e. they have some issues, as you said, with the posterior pituitary, i.e. they may have some issues with oxytocin and ADH. So let's say they have no ADH. If they don't have any ADH, then what happens?
Antidiuretic. So if they don't have antidiuretic, they're diuresing too much.
Sounds good. So anything related to that? Diuresing too much?
Yeah. So if you're excreting too much E, you have I mean, technically, I guess this from the bottom up, you can be hypotensive.
Okay.
But I don't think about the hypoglycemia.
Okay, so I like that. I don't like that. Okay, cool.
Right.
What about hyponatremia?
That's a possibility.
Okay.
Hyponatremia. Hypocalcemia. I don't believe so.
All right.
Deficient feeding of pups. No.
Just
Yeah.
okay. Okay. Okay.
And
No
constipation and cold intolerance. No, that's like thyroid.
Okay, so you said possibly yes with ADH,
Maybe.
possibly yes with ADH,
Yeah.
and then no for the others. All right, good. So now what about oxytocin? Is that related to any one of these?
So oxytocin, it's like if I remember, it's like it leads to like uterine contractions.
Okay, okay. So it contracts the uterus?
Yeah, and none of that.
Anything else? Okay, none of that. Is that it? Is that the only action of oxytocin?
No, it's not. But
What
I don't
remember. But we have a group here, yeah? And this group, I'm sure they all know. Somebody knows, right? Oxytocin. What else is a group?
Milk let down.
Milk let down too, right? Milk let down. Great. Okay. So between uterus contraction and milk let down, anything remotely?
So if you don't have milk let down, let's say oxytocin is blocked because you can't secrete it in these mice. So you can't let down milk, so she cannot feed her pups.
Okay, so we got one for oxy here.
Yeah.
All right. Anything else for oxy? Oxytocin?
I don't think so.
Okay, good. So cold, I think you said, what was it? TSH, right? Thyroid?
Yeah.
Right, that's parathyroid, possibly. Vitamin D.
Right.
Good. Now, let's take a real good look at ADH. ADH says antidiuresis, but here's my question. ADH, what does it really deal with in relationship to diuresis? What does it mess with? When you think of ADH, what do you think of really?
The aquaporin channels.
Aquaporin. And aquaporin, what is that, I guess, what is that associated with? What is that reabsorb? Aquaporin.
Water, yeah.
Water. So if I reabsorb, I'm sorry, now if I'm unable to reabsorb water, right, I'm losing a lot of water. Yeah. Right. So then what happens to my electrolyte levels in the serum if I'm losing all water?
Oh, they would be increased.
Exactly. With that being said, which one could you eliminate?
So we can eliminate D.
D is gone. And also,
Oh, and also
which
E,
other
because
one?
if you're increased electrolytes, then you would be hypertensive.
Thank you. No. You'll be
Oh,
hyperglycemic.
hyperglycemic, yeah.
But because you're losing water, you'd be hypotensive.
Right.
You see?
Right.
So had they mentioned maybe hyper, possibly, right?
Right.
But because they said hypo, we're down to only one.
And that is
Oxytocin.
okay.
Very nice. All right. Oxytocin is neurophysin 1. ADH is neurophysin 2. You got to know that. There was one question I saw and I said, this is ridiculous, but all right. Neurophysin 1, oxytocin, ADH, neurophysin 2. How do I keep them straight? If anybody knows me, whenever I say ADH, I always say ADH 2O. The 2. Neurophysin 2. Okay. Now, with that being said, who can tell me the nuclei of ADH and oxytocin?
ADH is supraoptic.
That's right, supraoptic.
And the other one would be
Paraventricular. Supraoptic and paraventricular nucleus. Don't forget it. Very important. Oxytocin, it causes milk letdown and baby letdown. That's the way I remember that as well. It lets the baby down, i.e. uterine contractions, right? Milk letdown and baby letdown. And it also allows for P letdown, if you want to think of it that way. Oxytocin has a very similar ADH-like effect. Very similar effect. All right. So it's very similar to ADH. I say, all right, well, sure, because they're in the same vicinity, yeah. So possibly, they may or may not ask that, okay? But just want to let you know that. That aside, milk letdown, baby letdown, and when the uterus contracts, we're talking about the muscle here. We have blood vessels within muscles, right? Everybody can agree to that?
Yes.
Yeah. Okay. So if the uterus, the muscle is contracting around the blood vessel, well, then will there be more or less blood flow to that area as it contracts? More or less? Less. Excellent. So woman comes in, she had some OB complication, and now she has uterine bleeds. Well, then you can give oxytocin to control uterine bleeding, uterine hemorrhage. Okay?
Okay.
Very important. Very important. All right. Very nice. So yes, neurophysin. Now, one last thing, I guess I can put it up here. Neurophysin, when I think of neurophysin, I just think of them as little highways, a little trail, if you will, right? We said we had the supraoptic nuclei. Let's put one up here. And we have the paraventricular nuclei right over here. And from there, the connection between them and the posterior pituitary, this is what I was trying to lead to earlier, Corina, is that it's like a little highway. That's all. Just a little tiny highway that drops off ADH and oxytocin into the pituitary, the posterior pituitary. Okay?
Yeah.
That's all it is, like little highways. All right, good. Okay, let's see here. Let some more people in. Wonderful. Let's see. I want to go with Jackie. There we go. Jackie, you're up.
Okay, I'm here.
All right. Let's rock and roll.
Which of the following is the most likely diagnosis? A 16-year-old girl comes to her primary care physician because she has never had a menstrual period. The examination shows Tanner stage 2 breast development and minimal body hair. Blood pressure is 150/90. The serum potassium level is 3.3.
All right.
What is the most likely diagnosis?
And as we can see, it's one of the hydroxylases, maybe a 5-alpha or an androgen insensitivity syndrome. So, what's going on here?
So, she's never had her period, and then she also has a really high blood pressure, and she's Tanner stage 2.
Right. So does she have
I don't think it's E.
Go ahead. Okay.
You can eliminate E.
All right.
Okay.
Which other one? Which other one could we eliminate?
You could also eliminate. No, I'll keep it there for now. That one always gives me the 5-alpha.
Good, exactly. Good. We're gonna eliminate it. But did everybody see what happened? You let the brain get in the way. You said, I'm gonna eliminate that one. No, let me not do that. Shut up, brain. Good morning. Good morning. I know it's early. Hey, brain, shut up. Go home. It's all about the gut. What does your panza tell me? Your panza told me 5 alpha is not it. Thank you, panza. I'm telling you. Stop doubting yourselves. You are doctors. You are doctors. Don't forget it. I think you all forget that. You're doctors, right? Did you forget? You just wake up one day, you forgot you're a doctor, right? You think you're like everybody else. Unfortunately, you're not. Or fortunately, you're not, right? We're only 1% of the population. You're doctors. Act like it. Uh-oh. All right. So with that being said, we're down to one of these, right? The 11, 17, or 21. So which one of these is associated with hypertension? Let's start off with that, right? Which one or one?
11
Uh-huh.
and 21.
Has hyper?
No, 17.
17 has hypertension. Okay, so 21 has? Well, if it's not hypertension, doctora, it's going to have to be hypotension, right? Yeah, if it's not up, it's down. I don't ask hard questions. Good, we're down to 2. Is it 11 or 17 hydroxylase deficiency? Standard stage 2 breast, minimal body hair.
The bottom answer.
Very nice. The bottom answer, we're down to the 50-50, 17 hydroxylase deficiency. So let's keep this straight. I've done this before. I need you all to have this very, very clear. We're going to do this VP in sex. With sex, we mean virilization. And virilization just means that boys become men. Girls become boys. That's virilization. Let's keep it real clear. So if they say a lot, if I say there's a lot of virilization or a lot of sex, there's a lot of boys becoming men or girls becoming boys. So you're going to put 21, 11, and 17. Anywhere you see the number 1, you're going to put an arrow going upwards. And there it is. In 21 hydroxylase deficiency, we have hypotension and virilization. In 11, we have hypertension and virilization. And in 17, which is this one, we have hypertension and we lack virilization. As a matter of fact, we lack all sex. So 17, I like to think of 17 hydroxylase as a 17-year-old girl. She was 16, close enough. A 17-year-old girl who's never had her menstrual period. 17 hydroxylase deficiency usually is about a 17-year-old girl who's never had her menstrual period. Okay? Lower Tanner stages of everything, Tanner stage breast, etc. All right? Very important that everybody remember this. Everybody has this clear, right? Blood pressure, sex. Yes, yes?
Yes.
Maybe possible? Okay. It's very important, very important. All right. Again, boys become men. We know that's the deepening of the voice, the acne, the hirsutism, or not hirsutism, but just the hair in many areas, Tanner stage 3 or 4 hair, pubic hair, etc., axillary hair. They might say that his penis has enlarged, his testicles have enlarged, or his scrotum has enlarged. All right. So we'll say, okay, interesting. Versus the girls, they'll say she also has acne, hirsutism, deepening of the voice, maybe a little more violent, maybe a little bit more or aggressive rather. Let me say violent, but I'll say aggressive, right? Increase in appetite, and very uniquely, the clitoromegaly. Be on the lookout for that, okay? The clitoral enlargement or enlargement, right? Clitoromegaly, which is the clitoris trying to become a penis. Girls becoming boys, okay? Hope they got it clear there. Now, to break this down a little bit further, okay, I do want to show you this. Now that we are here and it seemed like somebody was having issues with this, I want to make sure everybody has this clear. All right, I have done this before. Just keep it real simple. Everything starts with cholesterol. Cholesterol goes to pregnenolone. I'll just put pregnenolone. Pregnenolone goes to progesterone. And then progesterone will give me aldosterone, cortisol, or sex hormones. Put some arrows like so. All right. The enzyme that allows cholesterol to convert to pregnenolone is called, who knows? The enzyme that allows cholesterol to convert to pregnenolone is known as?
Cholesterol desmolase.
Yes, very nice. Desmolase. And the enzyme that allows pregnenolone to convert to progesterone, what is that one called? Ooh. 3-beta hydroxylase. Okay, look for 3-beta. Then from progesterone to aldosterone, you have to take 2 steps, 1 and 2. From progesterone to cortisol, the same 2 steps, 1 and 2. And you have to take a different step to get to sex. So we're looking at 21 and 11, 21 and 11, and 17 hydroxylase. Also remember, right in between, let's make this, make it green. Right here in between 21 and 11, right there in between 21 and 11, we have this feller called 11-DOC, 11-doc, right? 11-DOC. And you need to remember that 11-DOC is very, very similar to aldosterone, okay? So what happens here is this. If a patient has a 21 deficiency, look at that, we're unable to get to cortisol or aldosterone. So what happens to all the precursors? They go that way, towards sex. Right, like in 21 hydroxylase deficiency, right? That's why they have hypotension and a lot of sex. But with 11 hydroxylase deficiency, again, we can't get to aldosterone or cortisol. Everything goes back. The thing is, we bump into 11-DOC on the way back. And 11-DOC, what does it do? Just like aldosterone, it can cause hypertension. And then if they're missing 17, well, then we can't go this way. So very similarly, all the precursors build up and they go this way. And that's why they have hypertension. Okay. But for recall, BP and sex. All right. Everybody got that? Clear?
Yes.
Yes, no, maybe? All right. Very good. Very good. Very good. Let's go on to the next pollito here. Let's see here. We got Doctora Dianelise. Are you there?
Yes, I'm there.
All right. All right, Doc. You're up.
Okay. Which of the following is the most likely diagnosis in this patient? A 9-year-old boy is brought to the pediatrician because of neck mass. The patient says that the mass spread about 1 week ago and is late tender. He recently recovered from an upper respiratory infections. Temperature is normal, pulse is normal, blood pressure is slightly low, and examination of the soft mass is palpated in the middle line of the neck just superior to the larynx and move when the patient is asked to stick out his tongue.
Diagnosis?
And thyroid duct cyst.
And what makes you think that, Doctora?
And
I study, because I study, right?
in the middle,
I study.
in the middle. Go ahead.
I'm listening.
Okay. And the mass is in the middle line of the neck. Move when the patient stick his tongue.
Why?
Because
why does that happen?
He has a remnant tissue.
Yep.
Tissue of the thyroid.
Excellent, excellent, excellent. Very good. Okay, so thyroglossal duct cyst. There's a couple of neck masses that I want you all to make sure you know. All right, a couple of differentials. There's a lot of neck masses, to be honest, but there's about 3 or 4 that tend to come up often. All right, I've given this before. It's all review. So if it's found in the anterior midline of the neck, thyroglossal duct cyst. Fairly simple. That's this one. Moves with the tongue. There's an issue with thyroid migration, okay, from the tongue. What part of the tongue does it migrate from? Do we all remember? Let's say here's my tongue. Let's say something like this. And then here's a line. Do we remember what part of the tongue? What part of the tongue does the thyroid do it like that? What part of the tongue does the thyroid normally migrate from or descend from? Anybody know that? Everybody remember that?
In the floor of the tongue.
In where? What part? It's called the cecum. The cecum. That's here, right there. Okay. So you'll see a little tiny, like a little tiny hole right there in these patients as well. All right, in the cecum. That's where it is. It goes from there. Okay. All right. So, anyways, I digress. We come back. Thyroglosal duct cyst is one big one. Then you also need to remember of the brachial cleft cyst, which is on the lateral side of the neck. Okay. Clearly, because it has no tongue relationship, there is no movement. It doesn't move with tongue movement. Okay. Then you also have this little thing. It's like a little cyst over here, sometimes in the posterior neck. It's called the cystic hygroma. Which is seen in which disease? Who has a cystic hygroma? Turner's, very good, Turner's. It's another neck mass. And then the last one is your patient with cervical lymphadenopathy. Cervical lymphadenopathy. And who presents with cervical lymphadenopathy normally? Cervical lymphadenopathy.
Epstein-Barr.
Eso, Epstein-Barr, right? How do you say monkey in Spanish?
Mono,
right? Yeah, so mononucleosis, okay? Mononucleosis, cervical lymphadenopathy. So these are just four very, very common, very high yield neck masses that tend to come up all the time, okay?
May I ask a question? What about Zenker diverticulum? Does it come with
Zenker's diverticulum is not a neck mass. It is an esophageal pathology.
Yeah, but doesn't come with a mass, right?
No mass. Okay. What it does come with is a bunch of undigested food, and it causes halitosis and nasty, funky breath. That's what it comes with. So, but that's as much of a mass as you'll find with Zenker's. Okay. All right. Let's see here. That was, let me see if I got this voice correct. Amber?
Yeah.
That's what I'm talking about, Doc. You're up. Yes. Okay, Dr. Amr.
The hormone most likely to be elevated from in this patient produced by which area of the adrenal gland?
All right.
Okay. Do we have the GFR capsule middle? Okay. 18-year-old woman is referred to the specialist because she has not yet begun to menstruate. Her blood pressure is 160/99. She has she's hypertensive. Physical examination, tenor stage 1 of a breast development. Laboratory shows serum potassium level of 3.3. She is found to have a high level of a particular hormone. So she is hyperaldo because or we can say she's hypertensive because hormonal, and she doesn't have a progesterone and estrogen. Good. So I would say GFR, aldosterone, no, it's R. So it's zona reticularis. This is the deficient hormone.
So it says, no, they didn't say which one's deficient. They're saying which hormone is elevated.
Oh, so elevated.
And you said aldosterone is elevated.
Aldosterone, so G.
Where is he produced?
G in the zona.
All right. Very nice. You see? Very nice. So what do we have? We've seen this all before, right? We have our G, we have our F, we have our R, and we have the medulla, okay? Let's do this also, right? Remember, I'm all about A, B, C, D. I'm all about A, B, C, D. So we have, let's come over here, aldosterone, cortisol, as sex hormones, and norepinephrine, epinephrine, right? Catecholamines. Now, something else I need you all to remember is very high yield. Who stimulates aldosterone release?
Renin.
Renin, which eventually leads to angiotensin. Very good. Yes, renin, but it's angiotensin 2 ultimately that stimulates aldosterone. Very good. But what about cortisol? Who stimulates cortisol?
ACTH.
ACTH. ACTH. Very good. What
Both
about
of them.
sex? Both of them. Beautiful. Both of them. Oops. Sorry about that. Where was it? There we go. Both of them. Very right. Very good. Very good. And then what about norepinephrine, epinephrine, the medulla? Who stimulates it?
Cortisol.
Acetylcholine.
Acetylcholine. So I have AT2, ACTH, and ACH. Oof. This is what they like to ask about. Okay. Please get it right. They will. I've noticed that many students forget about this right here. This one in the middle. Please know that one. Okay. Please know that one. That's very easy to remember. Over here, acetylcholine. Acetylcholine stimulates the medulla via which receptors? Who remembers that?
You told us before. You told
That's right,
us
I did. That's right, I did.
muscarinic everything except neuromuscular junction and ganglia.
Excellent.
So,
and the medulla
nicotinic.
is nicotinic because the medulla is the medulla is skeletal.
Ganglia.
Ganglia. Very nice. Very good. You see? Perfect. So A, B, C, D. They say salt, sugar, sex. The deeper you go, the sweeter it gets. Right? That's the little mnemonic that they like to mention. Okay. A, B, C, and D. All right. Out from in. Cortex to medulla. Very, very important to remember this. All right. Amber. Nice job, Doc. Very good. Very good. Let me see. There was something else I wanted to quickly mention. Okay. The potassium. What's normal potassium levels?
3.5 to 4.5.
3.5 to 5.0 to 5.0.
Oh, 5, yeah.
Yeah. Okay, good. Here I see potassium of 3.3 with hypertension. So I see blood pressure high, potassium low. But in a way, blood pressure being high, you can also just relate that to high sodium. So whenever I see sodium and potassium going in different levels, the first hormone that you suspect is aldosterone. Always, always. It doesn't matter if it's going up and down or down and up, doesn't matter. The point is, if they're ever going in opposite directions, you're looking for aldosterone. Buzzwords for hypernatremia would be, of course, hypertension. And of course, they'll say high sodium. With potassium, it's a little bit more discreet. And other than the hypokalemia, they like to mention muscle weakness. So they give me a patient with hypertension and muscle weakness. They're kind of saying high sodium and low potassium. So be very much on the lookout for that, okay? Now, muscle weakness is not 100% related, it's not pathognomonic for hypokalemia because I've seen muscle weakness with hypocalcemia as well. But again, in this type of presentation where they give me the blood pressure and the potassium, or the sodium and the potassium, always think aldosterone. All right, nice job, very good stuff. Okay, let's see here. Margarita, you're up, doctora. Are you available?
Okay, yes, I'm here.
All right, yes. All right, doctora, what do we have?
Okay, which one of the adrenal glands shown in the figure normally synthesizes the hormone that is most likely responsible for this patient's symptom?
Okay, hormone responsible for the symptoms. What symptoms? What hormone is responsible for the symptoms? And where is it found? Okay, first, let's look for some symptoms, huh?
Okay, a 50-year-old man comes to the clinic with new onset palpitations, sweating, and jitteriness. His blood pressure is previously normal, is now 172/100. Serum electrolytes, creatinine, and glucose are normal. His 24-hour urine valeric acid is increased.
Diagnosis wasn't too bad. New onset palpitations, sweating, jitteriness. Blood pressure is high. It was normal previously. Diagnosis?
It's something that has to do, it looks like thyroid, but it's not a thyroid problem, no? Because they're talking about the adrenal.
Nice. So which disease of the adrenal gland looks like this or sounds like this? Palpitation, sweating, jittery, hypertensive. All right, who knows? Who knows? This is very straightforward. Yes, you do know. Yes, you do know.
Pheochromocytoma.
Thank you, pheochromocytoma. Now you're going to say, oh, I knew that, right? Yeah, right.
Oh, I'm sorry.
Turn that phone off, please. Thank you. We got to focus here. All right, so pheochromocytoma. Pheochromocytoma. Why? Because it's episodic palpitations. Episodic is the big buzzword, everyone. Episodic. Palpitations, sweating, and jitteriness. If they don't say episodic, they're going to say other words that mean episodic, right?
Yeah, that's why I didn't even think no intermittent or anything.
But they said this, doctora, right here. That's the biggest buzzword. That gave it away. VMAs. VMAs, yeah, the Video Music Awards. And HVAs. And metanephrines. All that in the urine. That's 1,000% pheochromocytoma.
Okay.
Okay. Unless it was in a child. If it was a child, then what's the child flavor of pheochromocytoma? What is that one called?
Neuroblastoma.
So neuroblastoma, not to be confused with nephro, because a nephroblastoma is another name for that is.
Is there something called nephroblastoma?
Oh yes. Oh yes.
Well,
Wilms tumor. Oh. Very good. Wilms tumor, nephroblastoma, and then neuroblastoma is the pheochromocytoma variant. All right, excellent. So now with all that being said, Dr. Margarita, we have pheochromocytoma. That is typically an issue of which part of the adrenal gland?
Then it's going to be the zona glomerulosa.
Okay. So with that being said, which one is the glomerulosa? Remember, glomerulosa, aldosterone is secreted, right?
Yeah, aldosterone that is stimulated by angiotensin 2.
So that's going to cause palpitations and sweating and jitteriness? Or is that only going to cause hypertension?
Hypertension.
Exactly. But we have palpitations, sweating, and jitteriness. Stop focusing on one detail. If I give you a piece of lettuce, you're going to say it's salad. And I say, haha, it's a sandwich. Stop focusing on the detail.
Exactly.
Location.
Palpitations, sweating, jitteriness, adrenal gland, hypertension, VMAs.
Then we're going to move to the medullary, which is ACH, norepinephrine.
Very good. The medulla, because that's where epinephrine and norepinephrine come from. That's all sympathetic, remember? Now, here's the hard part. Which one's the medulla here? I'll zoom it in for you a little bit.
The medulla.
Yeah.
The medulla has to be the deeper one, like number 5.
Good. Okay, good. Maybe number 5 is the deepest one. Maybe number 1 is the deepest one. But we went with 5. Great job. Now, what if they flip it and they do up and down? You see, what if they put the cortex in the bottom? What if they had put the cortex over here? Right.
Because it looks different. The medulla looks different histologically.
Absolutely. So what I want you to notice is something that I noticed. I was trying to figure out a way to clarify this for you all, okay? Because this is the thing is that they really like this specific question on step 1 and many MBMEs and comps, okay? Many of you who have taken MBMEs can vouch for that. You've seen multiple questions where they give you just this image and they say, what's the problem or where is it? So if we look closely, the cortex is the thinnest layer. Thin. See? So
and it's more dense too, more like
the thinnest layer. Okay, let me finish. All right, it's the thinnest layer. Cortex. Now, that's a capsule. Now, what happens is you have the glomerulosa. The glomerulosa, what I've noticed is that the cells are in column shape and they're vertical. Okay, they're in column shape and they're going vertical. It's kind of hard to tell here. I would recommend another image, but needless to say, they are going up and down. I don't know if you can see that here. Yes, it looks like they're going up and down, kind of, sort of. Yeah. Versus these that are going parallel. You see that? So I see up and down and parallel. So glomerulosa, let's make it yellow, is up and down. Fasciculata, see, like a big old F, is going side to side. Reticularis is doing this. It's going up, down, side, left, right. So if you can see closely, you see how it's going all over the place. So as soon as I see this side to side, and then I see something going all over the place, I say, okay, I know that immediately next to this guy would have to be the medulla.
Yeah.
Okay. What I look for is the fasciculata. Another giveaway, if you notice here, fasciculata is number 3. Look how wide fasciculata is.
Yeah.
That's another giveaway. That's another giveaway. Okay. This is for everyone to be on the lookout, because I saw this image and I said, I've never seen this image before. I mean, I've seen this histological slide before, but not this specific image, not this one in particular. And I said, well, you know, that there's different ones. Interesting. So in the event that they hit you with a different image that's not this one, I want to make sure you are prepared, right? And you know how to attack it. You say, okay, fasciculata, that's going horizontal, up and down is glomerulosa, all over the place is reticularis, and then next to reticularis is deep, nice and purple. That's the medulla, all right? Very important stuff. They do like this. They like this question. So be on the lookout for this type of question. Okay, good stuff, good stuff. Let's see, Dr. Ruan, are you there?
Yes.
All right, let's rock and roll, Doc.
Okay, so which of the following is the most likely diagnosis? 35 years old, woman visits her primary care physician after feeling a lump in her neck. Physical examination reveals a single, firm, non-tender nodule in the left lobe of her thyroid that moves when she swallows. Radioactive iodine uptake scan shows no area of focal uptake. Tissue is obtained. Histological section is shown in the image.
So without looking at the image, do you have a differential diagnosis?
If I see the image,
without the image. Yeah,
okay.
Without the image. And just 35 woman, lump in her neck, it moves with swallowing, no uptake. I mean, what could that could be anything, right?
Yeah.
Yeah, good. So what I want you to do is this. I want you all to get accustomed to trying to figure out what the answer is before looking at the images. Okay. Unfortunately, they didn't give us much information other than that it moves with swallowing, which immediately makes me think, oh, thyroid glossal cyst. But obviously, this is not that. So now we have to look at the image. And if I could just zoom it in a little bit. What do you see, Doc? Unique?
Let me see. Is this like a keratin pearl? Oh, no, Samoma body, is it?
Oh, maybe that's a Samoma body. Samoma. Do you see anything else? You see anything else? Anything else? It's right there. It's looking right at you. It's looking right at you. You see here. Like this, like that.
The orphan Annie eye.
There we go. Yeah, orphan Annie. You see that? Her ears. Right here. Here's one. Here's one. Here's another one. Here's another one. There's 2 right there, back to back. Here. Exactly. Orphan Annie cells. So we have Samoma bodies and orphan Annie cells, and you know that both of those combined in a fairly young woman tends to be which of the following? Is it toxic nodular goiter?
No.
Nah, it's not that. Is it thyroid glossal duct cyst?
No.
We just ruled that out, right? Papillary, medullary, or follicular carcinoma. Of the 3, which one can you eliminate?
The medullary.
Medullary's gone. I'm down to 2, 50-50. Doc, what does that gut say? What does your gut say? Does your gut prefer huh? Go ahead, gut. I want to hear your gut, not the brain. You're already taking too long. That brain is now getting in the way.
I think it's a papillary.
That's what I'm talking about. Oof, that brain almost got you. He almost got you.
Yeah.
Very good. Very good. Bottom answer. If you were unsure either way, you still would have gotten it right. Okay. Yeah, papillary. The P in Samoma body, the P is papillary carcinoma. Okay. The P is papillary carcinoma. Anybody else remember what the other diseases that present with Samoma bodies? Let's see, Samoma, I believe. Anybody else remember? It's like papillary of the thyroid. I believe it's meningioma.
Medulloblastoma.
Say it again.
Medulloblastoma.
Medulloblastoma, right? And I think it was is an ovary one.
Medullary carcinoma.
Medullary carcinoma. No, medullary carcinoma does not present with the small body.
Endometrial.
Endometrial. I just don't, because I remember the mnemonic is like PSMM. That's what I remember. PSMM, and the S was like serous cis-adenocarcinoma of the ovaries. Yeah. So we have an ovarian tumor, the thyroid tumor, brain tumors, meningioma, and is it medulloblastoma? I don't know if it's medulloblastoma. It's another one. Meningioma and tarea. I'll leave it for y'all. Look it up. All right. It's mnemonics. But Samoma bodies, what do they look like? Samoma bodies. Well, they say they have a world appearance. I don't know if I'm pronouncing that right. Worlid. They might say spindle shape. Okay. They might say rings on a tree. Right. If you ever cut a tree, it kind of looks like that, right? You cut a tree in half.
Yeah.
Yeah. So rings on a tree appearance, world appearance, spindle shapes. Kind of look, you're thinking more, yeah, warlid. I pronounce it warlid, but I'm like, I know that's not the correct pronunciation in English, but I don't know. Yeah, world, I don't know. Okay, good. Now, another thing is with medullary, I find medullary to be very, very unique. In that medullary carcinoma, he releases calcitonin. That's the first thing you got to remember. He releases calcitonin. What does calcitonin do? Who knows?
Calcium.
Yeah, decreases calcium. Absolutely. Calcitonin tones down calcium. Calcitonin tones down calcium. So if you have hypercalcemia, calcitonin will tone it down. Say, hey, enough is enough. Calcitonin goes to the osteoblast. I'm sorry, the osteoclast. It says osteoclast, enough is enough. We have enough calcium. We're done. Let's tone it down, huh? Let's take it easy. That's him. He has a little attitude, right? So medullary carcinoma, not only does it have the release of calcitonin, but also it has lots of amyloid. And you'll see amyloid as these bright apple green birefringence on a Congo red stain. So if they ever say Congo red stain, apple green birefringence in a patient with a disease releasing lots of calcitonin, which also C for calcitonin, C for C cells, parafollicular C cells, C for calcitonin, okay? It may also be related to men 2B and men 2A, okay? All of those are nice big buzzwords for medullary. Really got to make sure you all understand that because they like to mention medullary, parafollicular C cells, calcitonin, and they love to add this to the men syndromes. Okay, so I wanted to mention that. All right, excellent. Let's see here. Let's go with Dr. Lulu. Hey, Dr. Lulu, nice to see you. Well, good morning. Oh, is she there?
Good morning.
Hey, all right, she made it.
Which of the following is the embryology origin of the muscles of most likely affected by the surgery? A 56-year-old man is evaluated in the hospital for hoarseness on post-operative day, 1 day after thyroid resection. That had no apparent complication. Physical examination is remarkable, but he has hoarseness and then.
So hoarseness.
Yeah. Is the recurrent laryngeal?
Okay, perfect. So we're talking about recurrent laryngeal. Let's do that. I love that. Great job. Recurrent laryngeal nerve is predominantly responsible for hoarseness. And we know that the recurrent laryngeal nerve is related to which of the following? Is it the first, second, third, fourth, fifth, or sixth arch, pouch, or cleft?
Well, it's in the neck and then is the third pharyngeal arch.
It's in the neck. Okay, it could be the third. Yeah, it's in the neck. It is in the neck. So I see 2 for third. All right, so is it first?
No.
Nope, it's not first.
4, no.
4, probably not fourth. And
6,
now we're down to arch and clefts. Arch and clefts. And recurrent laryngeal nerve and hoarseness. Is it an arch? Is it a cleft? It's an arch. All right, good. So the cleft is gone. Beautiful. 6 or third? 6 or third? What is it, doc? Recurrent laryngeal. Let's go with third. Bottom answer. Oh, swing and a miss. Who knows what the answer was? The top one, the 6th. Now the question is why? The question is why? Why? The thing is, because where does the recurrent laryngeal nerve become the recurrent laryngeal nerve, right? When does he turn? Down in the aorta.
He made a curve in the aorta.
Exactly. Let me see if they give me an image. Oh no, they don't. They don't. Okay. But yes, exactly. He makes his sharp turn at the level of the aorta, which is down in the chest area. So I'm looking for 4th or 6th. Now, what you need to remember is this. Let me make a little drawing here. Very good though for thinking third. You're not wrong for thinking that. That's I was hoping you would at least say that, right? But remember, we have our parathyroid, superior and inferior parathyroids within the thyroid gland. And we have our third pouch, P for pouch, P for parathyroid. 4th pouch, P for pouch, P for parathyroid. 4th goes to superior. 3rd goes to the inferior. 3rd, TH for third, TH for thymus. Also comes from the 3rd. 3rd, TH for third, TH for thymus. Pouch, P for pouch, P for PTH. So 3rd goes to the inferior, 3rd goes to the thymus, 4th goes to the superior. These are pouches. These are pouches. These pouches, specifically these two, are the ones that are deficient in which disease? Who remembers? When they're missing the 3rd and 4th pouch? George, right? And Jorge, the George. The George. Very good. Exactly. So I said, all right, well, 3rd and 4th pouches is this, as I said, pouch for PTH. So with that being said, I said, well, it's not the 4th. The 3rd, usually 3rd is almost constantly associated with the carotids, So although you are thinking the neck and you're thinking 3rd, this one specifically is more so associated with the carotids when you think of 3 carotids, okay? And pharynx. But the larynx, that's 4th and 6th. So then that comes, so then that brings me down to here. And there it is, okay? What you need to remember is that the recurrent laryngeal nerve innervates the majority of your laryngeal muscles. Recurrent laryngeal nerve, let me just write that down here, make sure we all get this straight. Recurrent laryngeal nerve is it larynx? All of my larynx muscles, all of them. And then you have the superior laryngeal nerve, which goes to one specific muscle, and that is, who remembers that one?
Cricoid?
The cricothyroid.
Cricothyroid.
The cricothyroid. So the cricothyroid is the only exception of the laryngeal muscles. You have to remember this, everybody. Superior laryngeal nerve goes to the cricothyroid, the cricothyroid muscle. Recurrent laryngeal nerve goes to all of the other laryngeal muscles. So if they say hoarseness, first one I'm thinking of is this one, right? The one that goes to everybody, the one that goes to the majority, right? So that's it. That's just what I wanted to bring up to you all there. Very important stuff. Okay. Very good. Okay. Let's see here. Yes.
During the surgery of the superior thyroid artery.
Go ahead, doc. Go ahead. Yes, say it.
I think this external branch of the superior laryngeal is affected.
Boom. So let's say here's my thyroid. And let's say here I have, I'm sorry, right there, the superior branch of the which nerve? The external branch. The external branch of the superior. Exactly, laryngeal nerve. Superior laryngeal nerve. And if they were to have some sort of surgery where they just remove the superior pole, and here too, right?
Yeah.
You will not only possibly lesion the superior parathyroid glands, but you will also lesion the superior laryngeal nerve, i.e. they will have cricothyroid issues. Thank you for bringing that up, Amir, because this is something that they didn't ask about. This wasn't something that they commonly asked about up until the recent years, which makes me suspect that somebody's messing up in these thyroid surgeries. Somebody's nicking this nerve a lot. See?
Okay.
So good. That being said, remember here, these are my M and T structures. These are my S structures, M and T's and the S's. They just highlight the M. But remember, you have temporalis, tensor tympani, anterior 2/3 of the tongue, tensor palatini, and trigeminal. T for trigeminal. Okay? The third part, T for third, 3. So M and T structures versus the S's, they have all the S's there, right? You can put the S over here in expression and facial. So lots of S's, okay? All right, good. Next one. This is great. Let's see here, Maria K. You there, Doctora?
Hello, yes.
Hey, all right. We're looking for something elevated.
Which of the following is the most likely elevated in this patient? 33 years old woman presents to the emergency department after several episodes of syncope. She faints after standing up quickly. She notes weight loss, craving for potato chips, and generalized weakness. Her blood pressure is 94/60. Physical examination reveals areas of hyperpigmentation in the skin and gums. Several studies show a sodium level of 132, potassium 5.5, chloride 106, and bicarbonate 19.
What's happening in this patient? What's her diagnosis?
Okay, syncope, weight loss, driving south, hypotension.
So you see what you're doing here? You're reading it 2 times. I asked you, what do you think she has? And then you started reading it again, which means, what were you doing when you were reading it the first time? So this goes for everybody. When you're reading it, I want to make sure that when you read the first 2 sentences, you get a differential diagnosis or the diagnosis, meaning you should already be thinking, what do they have? What do they have? You see, because now what happens? We waste time. And Doctora, we don't have time to waste. They only give you 1 minute per question. Okay? So, yeah, but that's fine. I just want to make sure that you know what to do from here on out. Okay, so what's your diagnosis? What do you think this lady has? You should have some suspicion. Okay, who can explain? Who can give me an answer here?
Addison, maybe.
Addison's. Why Addison's? Why does it have to be Addison's?
Because she has both decreased hypertension. She has a lot of stuff, and also
like
hyperpigmentation.
The hyperpigmentation.
And hyperkalemia, which also.
Hyperkalemia, which, wait a minute. Didn't we
just said all though, when they opposite think of aldosterone.
Yeah, okay, so something's going on with aldosterone. Is it too much or too little aldosterone?
Too little.
Too little. Very good. So I have low aldosterone with
and low cortisol.
Hyperpigmentation, and then possibly low cortisol, but they don't give me they don't give me a reason to think. No, pressure is aldosterone. That's aldosterone.
Yeah.
They're focusing only on aldosterone, but they are saying pigmentation.
You can answer based on hyperpigmentation that she has high ACTH, because ACTH and MSH, they share the same, they are brothers.
Very good. Very good. Very good. So here's the hypothalamus, here's your pituitary, and let's say here's the adrenal gland. And as you were saying, we have corticotropin releasing hormone, we have ACTH, and we have cortisol. And we have cortisol being released. Now, what happens here is that, of course, we have, as you said, Addison's adrenal insufficiency, ACTH builds up. What you all need to remember is that right here in between CRH and ACTH is POMC, pro-opio melanocortin. The cortin gives me the cortisol. The melano goes to MSH, causing the hyperpigmentation. The opio is opioids, in particular endorphins. Okay, so let's say Amir.
Yeah.
You work out, go to the gym,
No.
lift tires and stuff. No, you don't flip tires. That's what people are doing nowadays, just flipping tires.
I'm just
no. Okay, good. Just studying. Well, I recommend you get some exercise done at least 3 times a week. It's good for stress release. All right, but anyways, enough of the public service announcement. Let's say you do exercise, right? Let's just say you do, like every day. Now, when you're exercising, exercise in and of itself is somewhat stressful to the body. When you're stressed, cortisol is released. In order to release cortisol, I need ACTH. In order for me to release ACTH, I need POMC, and from that I need CRH. So you exercise, let's say 1 hour, 1.5 hours, right? You go hardcore, maybe 2 hours in the gym, just clanging and banging, as they say, right?
Okay, yeah.
What happens afterwards? Well, you've produced so much cortisol that at the same time, you've produced a lot of ACTH, which means you produce a lot of pro-opio melanocortin, which is why at the end of a good workout, after you shower, you're still going to see a very darkening, almost like, it's kind of like I say in Spanish, a sucio, a little dirtiness in your hands. And you say, why do my hands look so dirty? What happens is that the lifelines of your hands are going to be hyperpigmented, because this is where you see the hyperpigmentation occur first in the lifelines. So your hands are going to look like they're dirty. You're like, why are they so dark? It's because of the exercise, all the MSH. At the same time, right after a good exercise, and maybe even right after a meal, you tend to feel very loose and limber, and oh man, I feel great. That's the endorphins. You see?
Yeah, it's all connected.
So, it's all connected. So do you now understand, everyone listen, do you now understand why exercise is stress relief?
Yes.
Yeah. You don't have to lift tires. You don't gotta, do 18 pull-ups or 1,000 pull-ups. You don't gotta do any of that stuff. Go for a nice walk. Maybe 20, 25-minute walk. That's it. Build a little sweat, get the heart rate up a little bit. Okay, you don't have to get tachycardic. You don't have to have the angina. Just go for a nice walk, a little stride, right? Listen to a lecture. Maybe listen to Golden while you're at it, or listen to one of my lectures as we go about the questions, or something. Make it productive, but about 20 to 25 minutes. That's all it takes. But it does help with especially if it's consistent. It's also been said that people who exercise consistently have better skin tone. I don't know. I'm not looking around at people's skin tone, but it's been said. And I'm like, all right, it makes sense, right? Why? Because of the MSH. So with that being said, very similarly, if they have Addison's, it builds up. ACTH, POMC builds up. Everything crosses over to the MSH, and therefore that's why they are hyperpigmented. Again, notice potassium, very high. Another thing is this. Why are they mentioning chloride and bicarb? What does that have to do with aldosterone? Who can tell me?
Metabolic alkalosis, when it's
but what's the connection?
When you have aldo is working, you excrete H, and that's make you metabolic alkalosis, your blood.
Very good. So I need you to remember there are 3 things. I always say it's 3 main things that aldosterone does. He reuptakes sodium, he decreases potassium, and he decreases hydrogen. So if I lose hydrogen, I will have alkalosis. But here, because I have no aldosterone, well, then you have to flip it. Yep, exactly. Oh, so I have a lot of hydrogen. So I have acidosis. And if I have a lot of hydrogen, I have very little bicarb. And if I have very little bicarb, chloride is going to increase. Normal chloride is about 100. Normal chloride is about 100, even. Okay?
Okay.
Everybody remember that? Anybody remember why? Like that connection? Right. Bicarb increases, chloride decreases. Chloride decreases, bicarb increases. Why is that true? Why does that have to happen? Anybody have any idea, a theory? Okay, here's something I want you to focus on. What's the charge on bicarb? HCO3.
Negative.
What charge? Negative. Good. What's the charge on chloride?
Negative.
Oh, interesting. So when a cell loses a negative charge, by the way, do we have any other electrolytes with a negative charge? Sodium, potassium, magnesium, calcium, iron, zinc.
Phosphate.
Phosphate. Yeah, well, phosphate, but that's not an electrolyte, right?
No, it doesn't. Yeah.
Not really. Okay, good. But for the most part, this is what I want. I want to show you this. I want to prove to you that for the most part, we only have these two negative charges. If a cell loses a negative charge, he has to replace it with another negative charge. Soup. Okay. Here's a good example. Let's see here. Let me choose somebody else. Let's see here. I'm gonna ask who haven't I spoken with today? I spoke with everybody. Very good. I spoke with you. All right, but okay. So Amir, since I got you here, I'll just use you right now. All right, good. Amir, after eating a big meal, right? Let's say you're married, right?
Yeah.
I believe. Okay, good. You're married. So is it you or your wife who usually cooks? Who usually makes the food?
My wife usually.
Your wife. Okay, I'm sure she does a fantastic job, right? So I'm sure there's one meal, which is your favorite meal. There might be more meals, right? But I'm sure there's one meal that you just say, honey, I don't know how you do it, but you did it again. I need to have 2, 3, 4 servings of whatever this may be. Yeah?
Yes.
Am I more or less? Okay, good. So here's the thing, Amir. In order for you to eat all this food, you have to produce hydrochloric acid in your stomach, right?
Yes.
All right, good. So we're in the stomach area. We're in the stomach. All right. We have to produce hydrochloric acid in the stomach. Now, the thing is, though, in order to produce this hydrochloric acid, remember this hydrochloric acid is made up of hydrogen and chloride. And this is found in the stomach. From the stomach, where does it go? It will digest your food and out the back, out the butt, out the back, right? Digesting the food.
Yeah.
Here's the thing, though. In order for us to create this hydrochloric acid, who remembers the enzyme that allowed that to happen?
Carbonic anhydrase.
Carbonic anhydrase. And we all know that carbonic anhydrase, as he's producing this hydrochloric acid, what else is being produced?
Bicarbonate.
Bicarbonate. Oh, wait a minute. So that means that as I'm secreting into the stomach, the hydrochloric acid, the acid, and the chloride, what am I keeping in the blood?
Bicarbonate.
Bicarb. You see that? Meaning I keep bicarb and chloride is being lost. They go in opposite directions. This is called the alkaline tide, by the way.
Wow.
This is called the alkaline tide, by the way. I just call it Amir's favorite dish.
Okay.
All right. That's all it is. It's just your favorite dish. And the more that you eat, the more bicarb you're going to produce. And Amir, check this out. If you produce a lot of bicarb in your body after a big meal, you produce lots of bicarb. How does CO2 respond to the high bicarb?
Okay, so increase
or decrease?
It has to decrease.
No, if bicarb increases to keep things equal,
it has to
increase. Amir, how do I increase CO2? Hyper or hypo?
Hypoventilate.
Hypo. This is when you start to yawn after the 4th or 5th meal, or rather 4th or 5th dish. You see that?
Yeah. Okay.
You get a little sleepy. Okay. It's called the alkaline tide, or Amir's favorite wife dish.
Yeah.
All right. Yeah. Good. In Spanish, we call it hartura. I think the kids call it full AF. Itis. I remember when I was growing up, it was called the itis. I got that itis. Whatever. All right. The point is, regardless of the name, you have to understand the physiology behind it. And it's all because of carbonic anhydrase. Therefore, that's why bicarb and chloride are opposite levels. Okay.
Okay.
You got it? Everybody got it? Good, 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 good. All right. Wonderful. Oh, last thing is carbonic anhydrase. I think I gave one of you a mnemonic for where you find carbonic anhydrase. There's a few tissues where you find carbonic anhydrase. Who remembers this mnemonic? If you have a mnemonic, who
It's
has
the
this?
blood, the kidney,
That's not the mnemonic.
stomach.
You're close. You're good. That's good. You got it. You're good. You're good. You got it. But who remembers the mnemonic? Anyone? Anyone? All right. So you're correct. It's beaks, though. It's beaks. Beaks. All right.
Okay,
Where do I
blood.
find carbonic anhydrase? In the beak. So B for brain, E for the erythrocyte, i.e. your blood, as you were saying, erythrocytes, the eye, the kidneys, and the stomach.
Yeah.
I know one of you know of a drug that inhibits carbonic anhydrase.
Carbonic anhydrase inhibitor.
Acetazolamide.
Acetazolamide, carbonic, of course, right? Really funny. Acetazolamide, very good. So guess what? With knowing beaks, then I can potentially say, I know where acetazolamide will work. I know what diseases will work with acetazolamide, right? I know which ones acetazolamide can treat. Like if they have high intracranial pressure, brain. Or if they have glaucoma, right? Right, Dr. Margarita? Right? Glaucoma?
Yes.
Yeah. Or it's a diuretic, kidney.
Mm-hmm.
Right? And then theoretically speaking, if I've never seen this question before, but I can see it. I can see it as a good question. They can potentially say also the stomach. It's not going to work in the stomach, or it doesn't work in the stomach, but let's just say in a lab experiment, in a rodent experiment, right? They'll come up with something. So just remember, carbonic anhydrase is also in the stomach. It's just acetazolamide wouldn't work there. But guess what? It covers the majority of it, right? So that's it. I don't have to try to remember the list of diseases that I can treat acetazolamide with. I just say, where's beaks? Where do I find beaks? Brains, erythrocyte, eye, kidneys. Good. That covers all of them. All right. So very nice. All right. Corina, are you there?
Yes.
Yes. All right, Doc, you're up.
Okay. Hypersecretion by which of the following structures is most directly responsible for this patient's findings? So they're going to have, you need to know where. Okay. 30-year-old woman comes to the physician stating that her blood pressure was high when she checked it in a machine at a local drugstore. Okay. At the office, her blood pressure is 160/100. Sodium level is 147. Potassium is 3. Renin is 0.4 and low.
Okay, it's low. Okay. So now they throw out the renin is low. Interesting.
Mm-hmm.
What's going on here, Doc?
Renin secreting stomach.
She has hypertension. Her renin is low.
Interesting.
Yeah.
What else do you see other than the renin being low?
Well, her sodium is high and her potassium is low.
Therefore, who is
so the aldosterone.
Oh,
yeah.
But then they said renin is low though.
So somewhere in the kidney. So we're not thinking really.
So it's not primary, you mean?
Maybe. I didn't say that. You said it. I didn't say it. You did. I'm not trying to give you the answer here.
Okay. Hold on. Let me see.
So you said aldosterone.
So yeah, so there's something with aldosterone because the sodium and potassium are going in opposite directions.
Sure. Absolutely. I asked you, who stimulates aldosterone?
Angiotensin 2.
Yeah, angiotensin.
Angiotensin 2. Right. Who stimulated angiotensin 2?
Angiotensin.
And who stimulated angiotensin?
Renin.
Renin. Interesting.
Okay, and we know renin is low.
Right. That's weird.
So that's what this is high.
Yeah. Therefore, this has to be. Therefore, this has to be what disease?
Primary.
Primary hyperaldosteronism.
Great, and we know that aldosterone comes from, you see? It's all,
Yeah,
it's all
from
the
the
same stuff.
from the adrenal.
You see how
Yeah,
it's literally the same question, but look what they did. The exact same question, but look what they did. Good. So remember, with renin, I've given you this before, since I know most of us speak Spanish here, so I'm going to make sure everybody gets this. Let's make it blue. With the raw system, renin-angiotensin aldosterone, right? Remember, everybody, I spell it like this. I put lots and lots of A's, okay? So for those that have not seen me do this, here we go. Renin plus angiotensin-ogen, which comes from the liver, by the way. Those give me angiotensin 1. Angiotensin 1 plus ACE, which comes from the lungs, will give me angiotensin 2. And angiotensin 2 will do 4 things. Angiotensin 2 does 4 things. 2, 3, 4. He will stimulate alpha 1. Let's see here. Stimulate alpha 1 receptors. It will stimulate aldosterone release. It'll stimulate ADH. And it'll stimulate thirst. Corina, how do I say thirst in Spanish?
Sed.
Sed. Tengo sed. All right, so I have renin, angiotensin, angiotensin 1, angiotensin 1, angiotensin converting enzyme, angiotensin 2, angiotensin 2, alpha 1, ADH, aldosterone, and sed, ROS. Got it?
Yep.
There's more A's than what they give you. They just say RAAS. There's so much more going on there than what they give you. Okay, it's the renin-angiotensinogen, angiotensin 1, angiotensin converting enzyme, angiotensin 2, alpha 1, aldosterone, ADH, and thirst pathway. It's a mouthful.
Yeah.
All right. So what I need you to remember is that now I know we're not supposed to be doing pharm, but I just want to quickly show you something. If I give a patient an ACE inhibitor, what happens to levels of angiotensin 2?
Decreases.
Decreases. What happens to angiotensin 1?
Increases.
Increases, you see, because you inhibited the middle. Don't forget that ACE inhibitors, okay, you'll have high angiotensin 1, low angiotensin 2. But what if I give a patient an angiotensin receptor blocker? I want you to remember that you're blocking here, right here. So you're going to have angiotensin 1, ACE, and angiotensin 2. Everything's going to be elevated, all of it elevated. But angiotensin 2 can never make it to the receptors of any of the others, of all the other A's, to alpha aldosterone or ADH. It never makes it there. Those are the angiotensin receptor blockers. Do not confuse them with ACE inhibitors. They will ask this in a chart. They're going to ask levels of AT1, AT2, renin, aldosterone, and you have to know the difference. One inhibits the receptor. Matter of fact, I would prefer that you do this. I know they call them ARBs, right? I want you to call them, I guess, A2 ARBs, A2 RIBs. Because it's angiotensin 2 receptor blockers, not angiotensin receptor blockers, angiotensin 2 receptor blockers. Okay?
Okay.
Please have that clear. Okay, we'll get it. All right, everybody, last question. This one is going for Jackie. Jackie. You're up, doctora.
I'm here.
Today. All right, we're looking for a vein.
It says, through which of the following veins does the second hormone most directly enter the systemic circulation?
All right.
So it's a 43-year-old woman presents to the clinic with enlargement of her hands, feet, weight gain, and tingling sensation in her palms. She complains of difficulty seeing things to her right. She is found to have elevated level of pituitary hormone that induces production of a second hormone to achieve many of its metabolic effects. So she has acromegaly.
Yep, acromegaly. Which you know is a problem of which hormone?
The growth hormone.
Right, growth hormone. Okay. And then growth hormone goes where? Or what is it? What's the next hormone after growth hormone? Let me actually start it over here off to the side to give me space. So we have growth hormone, and then he goes.
So
where?
Releasing.
Growth hormone released from the pituitary.
The GRH?
So from the pituitary, it goes up to the hypothalamus?
No, to the.
To the, yep. This is important. Everybody has to know this. No, we're already in the pituitary. We are in the pituitary. From the pituitary, where does growth hormone go? Who knows? Who knows? Growth hormone, where does he go? What organ does he go to? Say it again.
The bones.
The liver.
The liver, the liver. And in the liver, who comes out of the liver?
Insulin growth.
Thank you. Insulin-like growth factor 1. And then this guy goes to who?
To the bone.
To bone.
To muscle.
And muscle. In the bone, it goes to certain receptors. Let's say we have some receptors here. Which receptors is it going to on the bone? What are these receptors called? There's a unique name. Anyone? Anyone? Oh man. Somatomedin. I know you read it before. Somatomedin receptors, everyone. Somatomedin receptors is where insulin-like growth factor goes to stimulate bone growth. Okay? Everybody got that? Yes?
Yes.
No? Maybe? Okay. The reason why this is important is because what if a patient happens to have somatomedin receptor deficiency or a mutation of the somatomedin receptors? Can they grow?
No.
No, dwarfism. Okay. One of the many subtypes of dwarfism. Okay. Got it? Now, here's a real question, Jackie. Since we already know all of this, it says, through which of the following veins does a second hormone most directly enter the systemic circulation? Through which vein?
The hepatic veins.
Wow. Incredible. To be more specific, I would have said the central hepatic vein. That would have been an even better answer. Okay. Good. Makes sense? Yes? No? Maybe? You already got it?
Yes.
Good. Acromegaly. All right. Acromegaly. I think of acromegaly, or when I think of acromegaly, I think of Arnold Schwarzenegger back in the 80s. I don't know if you ever remember seeing Arnold Schwarzenegger back in the 80s, and you look at his facial profile, but he had a really thick jaw, right? Real thick jaw. He had widely spaced teeth. Yeah. He had a big forehead. They call it frontal bossing. Yeah. Everybody remember that? Everybody remember seeing him back in the 80s?
Yes.
Yeah.
Yes.
Now, not so much. Now, not so much. But in the 80s, yeah, he had the big forehead, the big jaw, the big widely spaced teeth. And see, here's something that's unique about that. If your teeth, let's say here's your teeth, and they're spaced in between, like so, then when the patient's tongue, when he sticks out his tongue, it's gonna stick out through here. So what happens is, over time, the tongue looks like this, and they say the tongue is furrowed. A furrowed tongue. Okay, why? Because the tongue is huge, you have widely spaced teeth, and this huge tongue is pushing up behind the teeth for so long, eventually it just has these little indentations. It's a very unique presentation, very, very unique presentation. Again, Arnold Schwarzenegger back in the 80s, not now, but back then. Why back then? Because back then we all know they were taking a lot of steroids and a bunch of other drugs that you can't take nowadays. But back then, there was less control. I'm sure they were taking like horse growth hormone and a bunch of other weird things too. All right. So stay away from drugs. Public service announcement. All right, everybody. Very good. Very good, very nice.
Doctor, before you leave,
Yes, yes.
can we like have a discussion like the last minute about